So Jeff's already given you a bit of a punch of how important pulmonary rehabilitation is in the management of COPD. And what I want to go through is a bit of an overview of pulmonary rehab. So talk about some of the benefits and barriers, go through the main components of what makes up a pulmonary rehabilitation program, and then talk about some of the future directions in this area. So the ATS and ERS recently modified the definition for pulmonary rehabilitation back in 2013, and this is the definition of what pulmonary rehabilitation is. As you can see, it is quite a meaty definition, so I have just bolded what I think are the key points: that it is a comprehensive intervention, so it is a mix of lots of disciplines and lots of different interventions together. It's patient tailored, so it's all based on an individual patient assessment, and the therapies include but are not limited to exercise training, education and behaviour change. So at the end of the day, we're trying to promote long-term adherence with health enhancing behaviours. Now, there is a huge body of evidence to support pulmonary rehabilitation, and in fact many international guidelines recommend pulmonary rehabilitation for people with COPD. So the NICE guidelines say pulmonary rehabilitation should be made available for all appropriate people. Their definition of appropriate people is those with an MRC score of 3. Or actually, if you've had a recent hospital admission, then that MRC score goes down to 2. The GOLD COPD strategy recommends pulmonary rehabilitation and even go further to outline the components which they suggest. And the COPDX, our Australian and New Zealand guidelines, say pulmonary rehabilitation is one of the most effective interventions in COPD and should be made available for all those with moderate to severe COPD, but also other people with long-term respiratory conditions as well. So there is, as I said, a wealth of evidence around for pulmonary rehab. It is conclusive that pulmonary rehabilitation works. The strongest evidence is in that pulmonary rehab will improve people's exercise capacity and improve their quality of life. But there is a growing body of evidence around reduced mortality and reduced hospitalisation, and it's thought that the most important time for reducing that hospitalisation is getting people into a program within 30 days from that admission. So some benefits that patients find from the program. This is one of our recent participants. For this chap, what he found was that getting up, getting dressed, having breakfast, half the day was gone. He was so slow in being able to get through his daily activities, he just found like he had no time. And at the end of the program, he said, "It's given me back a kind of lifestyle. I can now do things with more ease as they don't take as long. I have more time. It's more than I could have asked for, and I'm truly grateful." So
he's a very laid-back man to start off with. This is not someone who's anxious and highly wound up.
And another lady, "Just do it. I couldn't walk before. I'd be so out of breath, but now I can run and play with my grandkids." Okay, so the benefits to the person and family all come from being able to improve somebody's quality of life. So I'm going to go into these a little bit more detail, but it's not just about the physical benefits, because as we know, COPD is just not about a reduction in exercise tolerance. It has such a widespread effect with lots of different symptoms. So we look at the psychological issues, the anxiety and the depression, the spiritual, helping people develop advanced care plans, talking about what treatment interventions they would like, what they would like for the future. The social interaction, which is, I think, huge and probably attributes to the most success that people get out of the program. Reductions in mortality and morbidity, and also touching on some of the cultural aspects. So we always look at the cycle of inactivity with our participants, and it's a really simple cycle, but I think this demonstrates really well what happens for people with COPD. So they start to experience some symptoms, and being breathless is really scary. Perhaps they went to the supermarket, they got really breathless halfway around the supermarket, and I thought, well, I'm not going to do that again because that's just horrible. So they start getting someone else to do their supermarket shopping. Then they start to lose confidence, they start to drop off other activities which previously they would have done before. They get deconditioned, but they also start to become quite socially isolated because the more activities they involve, they don't want to go shopping with their children because they walk too fast and it's too embarrassing. The anxiety and the depression really starts to kick in, and so this cycle perpetuates more that they avoid and less conditioned they become. So in addition, there's lots of benefits to the healthcare provider of a pulmonary rehabilitation program, and as Jeff has already shown, the program is cost effective. We're really third on the pyramid, not quite as effective as the flu vaccination. A typical 8-week pulmonary rehab program costs approximately $600 per patient, which when you equate that, that's half the first night in hospital. As well as if we can improve the concordance with their medications, then that's got to be cost effective as well. There's clear clinical benefits, there is a flexible service, and it's very evidence based.
Sorry, how many on your course? how many? You had 600
How many at any one time?
Yeah.
So at counties we have 4 programs running all year round, and we in each site, so we have 4 different sites. At each site we have 2 programs running per day, and each class has 12 participants, so 24 participants a day.
They're not always full, and we have bent the rules for a few patients. One person who in the past 3-4 years has had 15 presentations to Middlemore each year. We've kept him in pulmonary rehab, and he's had 2, and he's been coming to 2 in the past year.
How long do the effects last?
About 18 months.
The effects of quality of life last a little bit longer than the exercise benefits, and it depends a little bit on the length of the program as well. So longer programs, the benefits last a little bit longer. Our program is 8 weeks. It comes down to the participant and what happens at the end of the program often.
Do you want to talk about that? Because I think your experience with the hospital-based versus the community-based ones has been a bit different. Are you going to talk about that later? Oh, okay, sorry.
So we know that pulmonary rehab works. Oh, sorry.
I was just saying that we've been fortunate to have a post-grad walking group, so the people that have completed the program are carrying on.
Fantastic.
And we make it their responsibility and give it back to them, and it's working out really good, and we're having really good results. Like the physicians from the hospital can't believe the FEV1 is actually improving on these people. So, yeah, it's been really great.
That's great when that can happen, huh?
Do you also look at the family environment that they're being discharged into?
And some
You're suboptimal, aren't you?
Yeah.
It must
Some we can, some we can't.
suboptimal.
Yeah.
Yeah.
A lot of it we can't always change, but what we find is, I'm just thinking about our young guy that we had last year halfway through the program, who had quite a young man with quite severe COPD. He'd been a lifelong marijuana user, and he came in, he's got a mouthful of broken teeth, and he's not eating properly, and he's just given up smoking, and all of these things going on, and in between there's some assault charges and some police involvement. And the only thing that changed in his life was coming to the program. Didn't get his referral for the teeth action till after he'd left, but his improvement in his 6-minute walk tests, but particularly in his quality of life scores and in his anxiety and depression. When we did his reassessment and we said to him, look what's happened to you over the course of the program, he burst into tears, and we then had to go and make photocopies of it so he could go, and he went and visited his father on the North Shore to put on his father's fridge to show him how much better he is, and he went and put it on his friends, and and that was, the social circumstances were very difficult, but nothing had changed in the social circumstances. It was just how he felt about himself from coming to exercise and learning more about his condition and taking some steps for self-improvement. And that's what we see quite frequently, because we can't always do things about social circumstances, unfortunately.
So we know that pulmonary rehab is effective, yet in New Zealand the uptake of pulmonary rehabilitation is actually really low. And William Levac did this study in 2002, well, it was published in 2002, but the survey was actually carried out in 2009, where he carried out a postal survey to all the pulmonary rehabilitation providers in New Zealand. And what the conclusion of the study was 2 alarming facts, that of the estimated population with COPD, only 0.9% were offered pulmonary rehabilitation, but actually only just over half of those, so 0.5%, actually even completed the pulmonary rehabilitation program. So there's kind of two big problems. We know this intervention works, and yet there's only a tip of the iceberg. But in speaking to Sue and Carol, I know that in Hawke's Bay they've got funding to expand their programs, as we have in counties and other areas have as well. So it would be interesting to see if the survey was done again, if there was much difference in those results.
Are your participants all who come from hospital post-exacerbation?
No,
So how do you get your participants?
So the referrals come from GPs, from the physiotherapists working on the ward, the nurses working in the ward, from the consultants in their clinics. So they come from a wide range of sources. That's nationwide.
2002, nationwide.
That was not counties data.
One of the things we have noticed is that it was 2 years ago, they started putting the reliever physios cycling through pulmonary rehab to come down and work as a session a week or a session twice a week with us, and that has increased the profile of pulmonary rehab in the physio department right across the hospital. So I think that has had a positive impact on our referrals.
I reviewed it about 2 years ago. It's about 7%, I think, at the moment, based on the prevalence of COPD and GP practices in counties Manukau. It's about 7% has been through a rehab program in the last year.
When William Levesque's study was done, they compared the data to Australia and Canada, which were also less than 2%, so we were quite consistent with international data. Yeah. We've found with our community programs, as we've become more embedded in the community, we get more referrals from GPs than we do from the consultants. Yeah.
And in actual fact, that's one reason why we have SMO oversight of our assessment clinic, and why we do quite a comprehensive assessment, because we're very conscious that patients are coming in to respiratory basically as an FSA for the first time. So that's hence case conferences that we have every week, and we discuss every patient with our docs.
So the literature's identified two subgroups of potential barriers to why people aren't going to pulmonary rehab, and they referred to one group as the non-attenders, so those that get referred to pulmonary rehab but they never come. And I know at counties we get on average about 75 referrals to pulmonary rehab per month, and of those 40% would not make it to the initial assessment. And the thing that you always hear is it's because of transport and it's because of the parking costs. But in reality, I think that's the easy excuse that people use, because we took the programs to the community, we put it in their backyard where there's free parking, and yet there can still be issues with non-attendance. But it is largely influenced by the referrer and people understanding the benefit that they're going to get from the program at that point of referral. The selling of it. So I think if the doctor says, here you go, you should go to pulmonary rehab, it's an exercise program. Full stop. Like, ooh, I don't exercise.
They say I can't get up my steps at home. How can I exercise?
So it's an understanding that it's more than exercise, and it's exercise at a level that is going to be achievable.
So one of the things that that Sarah and her thought really, really carefully about when they moved the programs into the community was, how do we rebrand this? And this is why pulmonary rehab, who understands what that means? You know, the word rehab often has negative connotations as it is, which is why we call our programs better breathing programs.
Thanks. Yeah. So there's also lots of reasons why people drop out of the program. And one of them is smoking. We have no problem with current smokers coming along to the program, but I think that often people who are still smoking feel a little bit judged. And also it is known that people who have high rates of depression and not a lot of social support are also less likely to complete. So moving on to what the components of a pulmonary rehabilitation program actually include. If we go back to the definition of pulmonary rehab, I want to focus a little bit around the exercise training and the education and behaviour change. I think we've talked about assessment enough this morning, except to say that at the end of the assessment we always derive patient-centred goals, and these are SMART goals of what the patient wants to achieve from coming to the program. And I think this is a really crucial part, because this is what gives the patient the buy-in, this is the hook that keeps them coming. And for a small group of our participants, we trained them up, and we did a 5-kilometre fun walk, and it was a massive achievement. And this is a few of our participants on the walk, and for some of them this was something they never dreamed that they would be able to achieve. That's not the typical goal that we make, but it was quite a fun little project that we did. Usually the goals are to be able to do their own grocery shopping so that they can buy the brand of washing powder that they like rather than the cheaper brand that someone else buys, or to be able to mow their lawns without having to stop 3 times.
So that fun run, actually it was great because they had all these corporate teams there, and then there's all our patients, and our patients cleaned up all the spot prizes.
We did.
The only fly in the ointment was that they'd cut the grass the day before, and so we were nursing one of the ladies who's got asthma around the course, but yeah.
So exercise is an essential component of pulmonary rehab. It is not the only part of pulmonary rehab, but it is certainly sets the foundations for the program. And how it works is it's group exercise sessions, it's supervised exercise, and programs vary between 6 and 12 weeks in duration. Most programs in New Zealand are 8 weeks, so people come in 2 times a week for 8 weeks. And it's a circuit-based program, and it employs the principles of interval training. So we are going to train those oxygen-hungry muscles in one station and then follow that up with something that's a little bit easier so that they can recover and get through a 45 minutes to 50 minutes worth of exercise. So we have a strong basis of aerobic type exercises, but as we know, because of peripheral muscle strength loss, we need to incorporate some resistance exercises as well. So in addition to coming in twice a week, they will all have homework, which they need to participate in exercise another 2 to 3 times at home. And all their exercise training program is going to be based on the goals that they've set, but also on their assessment. So they all have an individual based exercise program rather than just all having to follow the one program. So, as I said, we need to be doing 20 minutes in our programs of aerobic-based exercise, and this is usually made up of walking and cycling. So there's been some studies that have looked at whether treadmill walking is better than ground walking, whether ground walking is better than cycling. I think at the end of the day, we just need to be getting people exercising, and that more importantly comes down to what they enjoy. And also, no one just has COPD in isolation, so we need to take in all the comorbidities, their joint pain, their old injuries, and find out what they're actually going to stick with. We always incorporate strengthening exercises, as I said, both upper limb and lower limb, and this is going to be based on some resistance testing. And we've got some exercises that we can show you from the robot study, and perhaps we can leave that if time allows. So then there's many other components other than exercise training that make up a pulmonary rehabilitation program. And firstly, if we look at establishing social networks, so on that cycle of inactivity, I talked about how people have become quite socially isolated. When they come along to pulmonary rehab and they see other people exercising, they see other people that are short of breath, perhaps someone's carrying oxygen, they're worse off than me, if they're doing it then I can do it. That peer support really works, and often it forms bonds and friendships that continue on a lot longer than the program. Pulmonary rehabilitation is a great time to facilitate smoking cessation. So we always start that conversation, try and help people to set a quit date. We have a fantastic resource of smoking cessation specialists who we bring in for some one-on-one counselling. And I think because we're seeing people twice a week for 8 weeks, it's a good time for them to try and give up, because they can come and tell us about the side effects from their NRT or what's going on with their sleep and their cravings and all those other ghastly symptoms they go through.
And we also celebrate it, you know, so-and-so, it's been 4 weeks, they haven't had a cigarette today, you know, and it becomes a group celebration.
It's also a great time to optimise their medication, and I think Nicola's talked about this so well already, but it's not that their medications haven't been prescribed correctly, it's often they will have had a hospital admission and their medications have changed and they're confused, or they just aren't taking their medications correctly. We also spend a lot of time helping to detect the early signs of an infection. So all patients need a written action plan and spend a lot of time going through what are those early signs that are often missed. And it's not that we're going to reduce the number of exacerbations that people have, but our aim is to reduce the severity of those exacerbations. So the sooner you get to the GP, the quicker you're going to recover and the less severe this is going to be.
And often people find it really reassuring to come in and say, I'm really not feeling today, and I say, okay, sit down, and we check out pulse oximetry, we listen to their chest and say, well, you know, I'm suggesting that you go and see your GP today and you shouldn't be exercising. And they go, oh, I've been lying there wondering whether I needed to see him, and they made those excuses, my doctor's so busy and all of those things, I'll just wait a little bit longer. And so hopefully by the time they finish the program, they get an idea that they need to stop putting themselves at the bottom of the queue and actually take the action when they need it.
It's also a lot of work around managing the shortness of breath. So teaching patients rest positions, teaching people about pacing. So rather than just thinking, I need to get over there, I'm just going to hold my breath and get there as fast as I can, which is often what we see about teaching people to breathe as they walk, breathe as they talk. We give out super strollers, so walking frames, a lot to help people manage their breathlessness, and I'll talk about that a little bit more. And then some breathing techniques, pursed lip breathing, forward lean position, what to do when you get to the point of breathlessness and it's getting a bit much. We also really encouraged increased physical activity levels, and this is not about exercise, this is about increasing the amount of activity that you're doing every day. So take on some of those jobs at home that your family is saying, no mum, you sit down and I'll hang out the washing, or you just sit there and I'll get you a cup of tea, is for them to take control and say, no, I can do that, and be more physically active in their whole day to day.
We sometimes prescribe making cups of tea or checking the mailbox to patients, particularly when they've got families that are adamant that they have to sit on their chair and stay there. Yeah.
Looking at body composition, so we obviously get the extremes. We have many people with a BMI of 50 plus coming through the program, so we need to work at both ends of the scales. Improving the mental health, so identifying those that have high levels of anxiety and depression and guiding them through what needs to be done.
We're really fortunate. We have a very good health psychology service at Middlemore, and sometimes they are overstretched, so we'll also work in with the patient's GP practice and the PHO to find out what resources are available in their community. We'll also use things like early morning bright light therapy and just talking to them about just practical ways that they can help improve their mental health. ACP.
And ACP. So we introduced the concept of advanced care planning in one of our talks, and then give people the opportunity to develop a care plan. So most pulmonary rehab programs will have an education component that goes alongside the exercise. So usually we exercise for an hour and then have a half an hour meeting, as we call it. And the goals of the education sessions are to help people to become more active participants in their own healthcare. So really we're giving them a better understanding, what are the changes that are happening in their lungs, what are the changes that are happening in their body, and how can they cope with those changes. So they're not lectures, we're not up here like this, standing behind a podium. They're informal interaction sessions. We sit down, we have a chat, what worked for you, and we facilitate the session. And we try and bring in as many members of the MDT team as we can. And in our community programs, we try and bring in community pharmacists, community dietitians, OTs that are out working in the community, so that it's very specific to that community. So we will tell people what talk's coming up this week, so have a think about this, write down your questions, bring them along, and we try and make it strongly focused around the self-management strategies. So this is just an example of the different talks that we cover in our programs. Everyone's programs are slightly different. In Australia, recently they undertook a survey of 200 participants who had been through pulmonary rehabilitation, and they asked them which talks they got the most benefit out of. So I've underlined the ones which participants felt were the most beneficial to them. So I've put down the different speakers that come in and do the different talks. And these are just some more of the talks that we have. So participants liked learning about the breathing control techniques. They liked learning about the nutrition. They love it when the consultant comes out and tells them about what's happening in their lungs, and usually that half an hour talk becomes an hour because...
So you're saying, go, quick, go and exercise, we'll talk about it.
They love knowing a bit more about their medications and how to use them, and also a great session that our health psychologist does around positive coping mechanisms. Okay, so some of the other considerations in pulmonary rehabilitation is that we give out these walking frames. So why are we doing that? I want to touch on portable oxygen, but we could talk about that for a long time. and body composition as well. So often people that are severely short of breath benefit from a walking frame, and there have been a few studies that have looked at this. So it's not so much given out for their balance or their mobility, but to give them something to fix the shoulder girdle so that they can use their accessory respiratory muscles and also get them into that forward lean position, which is a lot easier to breathe. And people often naturally find that when they go to the supermarket and they hang over the supermarket trolley, they can breathe a little bit better. So therefore, issuing them and trialling a walking frame in pulmonary rehabilitation has the same sort of effect. For anyone who is on long-term oxygen therapy, of which we have quite a few who come through our pulmonary rehab program, we always exercise them on oxygen, and usually they need 1 to 2 litres more while exercising than they do on their LTOT at home. So those people that do have long-term oxygen therapy will be on it for a minimum of 16 hours a day. And it is important that we exercise them with a portable oxygen bottle as well.
If we're concerned about there being a CO2 retainer, we'll bring them back into clinic, do a little trial on the higher level of oxygen and then do blood gas just to check what's happening to their CO2 at that particular point.
There is another subgroup of people who need ambulatory oxygen or training oxygen. So when we do a 6-minute walk test, if somebody's oxygen levels drop below 88%, and we can't manage that with pacing strategies or interval training, then we will consider the use of some training oxygen while they're exercising. Now, there is no evidence to show that this has a benefit in their exercise performance, but it's a safety precaution to help reduce some of that hypoxic vasoconstriction. So we have portable oxygen delivered at all of our community-based programs and have that available as it's required. Did you want to talk about portable oxygen at all any further, or just leave it at that?
I think when we evaluated, we did actually a study on this when I was at Green Lane Hospital on portable oxygen, and one of the criteria we made was that people had to have first of all attended a pulmonary rehab program, because I think those are the people that are more likely to benefit. And we introduced it to them at the time of the rehab program so they worked out how to use it best. And we then randomised them to air versus oxygen, and the oxygen group actually ended up significantly better off than the air group after discharge. But on average, they're only using it about 2 hours a week, so a lot less than what we anticipated they were going to use. But I think portable oxygen, if you look at the data, actually contributes more to improvement in quality of life than does long-term oxygen therapy. Long-term oxygen therapy has impact on survival, and it doesn't impact until people have been on it for about a year. And the reason it does that is it reduces the impact on end organs, so they're less likely to die of their cor pulmonale or of renal failure, but they actually don't feel any better, mainly because they get attached to this device for 16 hours a day, which is what they have to take as a minimum amount for it to offer a benefit. So if you actually look at quality of life, the greatest benefit is actually from portable oxygen, and so the physios evaluate it and administer it, and I don't know whether you've got any data on that. Are you going to share any data on that or not? No. But I mean, how many people are on portable oxygen now?
Well, there's a huge number of people in South Auckland and now DHB that are actually on portable oxygen, but most of them aren't using it as correctly or as effectively as they could. For instance, they will have the portable oxygen on in the car, drive to the supermarket, and then they'll get out and walk around the supermarket on air. So there's a little bit more education in how it is going to give the benefit.
Yeah. They need to be educated on how.
And some of that is because of the size of the cylinders, and some of that is because of the weight of the cylinders and the hassle of getting in and out of the car, and
looking different.
And looking a bit different with the nasal prongs, and yeah.
Yeah.
So we could talk for a long time on that, but we won't.
We've had to recently change our criteria for portable oxygen because it's not actually funded, and it was blowing out the budget a little bit. So now we put people on a trial of portable oxygen for 6 weeks, on a very strict trial of 6 weeks, and assess their quality of life, their 6-minute walk test, and their usage over that 6-week time. And surprisingly, the people who we start on the 6-week trial who are going to join Green Prescription and really keen often don't use it at all over that 6 weeks. So the idea is there, but when it comes down to practice, they don't always use it as they should. But they're very reluctant to give it back because it's very reassuring to have those little bottles at home just in case. Yeah.
And the families often are pushing it, and the patient may not actually really be wanting it, and that's another problem that we run into then as well. But that means more time that we need to educate the family about the actual benefits of it and when it's useful and when it's not useful.
And thinking about body composition, it used to be thought that those with a low BMI, particularly less than 19, were contraindicated to come to a pulmonary rehabilitation program. That's not thought so anymore. We do know that those are the little ones with the really low BMI do have a greater risk of mortality. However, it has been shown in several studies that if they come to pulmonary rehab and have some muscle strengthening in conjunction with nutritional supplementation, then they will get improvements in their weight, but also in their quality of life. So it's absolutely okay for the little ones to come along and exercise. We just monitor them very closely and make sure that we liaise with the GP and the dietitian around some supplementation.
We've actually found that there's been a really good effect on some of those patients with low BMI, particularly where their home circumstances weren't so great, and then we've been able to encourage them, so what are you going to have for lunch today when you get home from the program? And then they'll come to you and you'll say to them, what did you have for breakfast this morning? So it's almost like encouraging them to eat, and then as they eat a little bit more and they gain a little bit more weight and they get a bit stronger, then they're coming to you and saying, guess what I had for dinner last night? And so it's not making it sort of obsessively about food, but it's more like cueing them back into eating, because if they've been eating too little, then they're losing their appetite, and that drives that downward spiral.
What about age and frailty? I mean, I can think of the COPs who are in their 60s and 70s, and then there's the ones who are in their 80s and 90s. Probably not going to be doing the same stuff, are they?
Well, because their programs are individually prescribed, they can still come to the same group exercise session, and it's amazing how many people we have in their 80s and 90s who actually do really well. I guess the biggest concern we have in a group exercise problem comes from their balance. So if somebody has a history of falling, then we need to do balance testing and ensure they're safe, because depending on the space, particularly in gyms, I think if you're doing your exercise program within a gym, often the equipment is quite close together. It's a little bit harder for walking frames and to negotiate your way around, and therefore safety is paramount.
And we've seen that how seated exercise programs can be very effective. And with some of those frailer people with the balance issues, they'll often be given seated cardio to do, and quite a seated component to their program, and then halfway through the program we're able to up the intensity, and you know, some of them they start off with walking frames and things, and by the end of the program they don't need those at all because things have improved so much.
And then looking at helping those that have the high BMI. So we do require some industrial strength exercise equipment in many cases, and it's finding activities which some of these bigger people can do which is comfortable and doesn't hurt their joints. Obviously water-based activities is ideal because that's taking the weight off their joints, and it's a lot more comfortable to exercise. One of our chaps recently, just last week, wanted to start in the doing some water-based activities. He was financially not in a position to get the required equipment, e.g. togs, but we, through Lung Health, managed to get him a 7XL rash shirt that he could wear so that he could start doing some water walking.
The Otara program sits alongside a free community pool, which is where we would direct those who are doing that.
What often is a problem for these people is they think because they're exercising that they can overcompensate a little bit with the diet. So the diet and the exercise have to go hand in hand to get the results that they need.
So we keep a good eye out for those energy drinks and things that start coming to rehab with them, and protein shakes and stuff like that.
So some of the future directions to pulmonary rehab, I think that William Levac's study was quite alarming for many people, and I think that it highlights there is a need for an increased access to pulmonary rehab, and this requires a little bit of different thinking, particularly in the smaller centres, around different models. I think at the end of the day the programs have to be patient focused, and so catering them to that community or to that group which they're serving. There is a real drive for programs to move away from the hospital sites and out into the community. And at Counties, we were lucky enough to expand into 3 communities a couple of years ago. So we are seeing 3 to 4 times the number of patients that we were previously seeing. And one of the projects that we're working on now is the role of peer support workers. So this has always been done in mental health and done very well. And we're looking at how we can incorporate this into our pulmonary rehabilitation programs. And I think this is particularly important in our groups where there's high rates of Māori and Pacific participants, the support workers who know what it's like to be breathless, who know who understand the issues that people are going through, can be really beneficial in helping to get people into the program and engaged and make those lifestyle changes. Another area which is the maintenance program, the nice to hear of your walking group, because I think at the end of the program people need to continue. It's no good doing this great work for 8 weeks and then going back to your previous lifestyle. We can't store the benefits of exercise. The benefits are only going to last as long as people continue with the exercise and the lifestyle changes. So green prescription and other community programs are great. In many communities there is a gap, and I think it would be great if we were able to develop some more phase 3 type programs that people could stay at for a longer period of time. In Australia they have Lungs in Action, which is a fantastic program which people go on to following pulmonary rehabilitation, which it could be peer-led. It doesn't need to be driven necessarily from the health professionals. There's lots of options around to help people to increase their activity levels. There's apps, there's apps for everything, but there's some great apps around. I think the role of pedometers and accelerometers and Fitbits, all the little gadgets, can be really great for encouraging people to be more physically active. William Levesque is doing some more study looking at rehabilitation, so some exercise groups in rest homes where they're getting people exercising with different programs. I think at the end of the day, the most important message is that a pulmonary rehabilitation requires all those building blocks. So exercise on its own is not going to achieve all the benefits that a comprehensive pulmonary rehabilitation program is. So it requires the support, the education, the coaching, the assessment and the exercise.